The next speaker is Dr. Rajkumar Gajmer. He is Pathan Academy of Health Science, and he will be talking about the fellowship in palliative care, report of the first completion rotation. I think we talked before also, the palliative care specialization program has started in Nepal, and he's the first man who completed the palliative care specialized program from Nepal. So welcome, Dr. Rajkumar. And in fact, I was lucky to observe him when he was doing his fellowship in the Palung area working. He's a very, really dedicated palliative care physician. And I was his examiner also. So he did excellent the examination to get his fellowship. Thank you.
Thank you, sir. Namaste, everyone. I'm feeling quite nervous in speaking in front of my teacher here. And it is my privilege being introduced by Dr. Vishnu here, and who was my examiner and who is a mentor always. And thank you very much for providing this platform for me to speak. Dan, where are you? And, and all the people here attending this international conference. Coming from medical school after passing, let's say 2013, I used to think myself as a big doctor, a very big doctor working in the eastern part of Nepal. But after working in rural areas, studying in one of that time, a best college in Nepal, I realized that after working in rural areas, I realized that I hadn't studied a lot. There was many things in the book, but there was many more missing things in the book. And learning from those incidents and patients and situations and all the difficulties, I came here as a speaker today is feeling very blessed. And I'll be continuing with my presentation. I think I will try to cover it in the 10 minutes. This was me trying to balance myself after completing my medical school, working in the rural areas. I'll be showing you all what things we did in. I had a lot of certificates with me, MBBS, MD, and different trainings and all. And what impact it made to the patient? That was the biggest question that I had. And after this, the COVID came. I was posted after completing my MD from government, I had to do 2 years payment of, we have to work under government for 2 years. And this was my first posting in Gandaki, in Tanau. And we were the first to see the COVID case in that district. We did our duty for 2 weeks, continuously isolation duty. And from here to posted in Katari Hospital, that is one of the remote area, as a medical superintendent. And as a medical superintendent, as a medical student, we are being taught to see the patients, and we are not taught to run the hospitals. And we have to do the executive work also there. So that was quite challenging there. And again, the second wave came, and we had to operate a surgery. As a GP, we did an emergency LSCS in COVID patients at that time. And distributing vaccine was also a challenging work at that time. Then after I was posted in Bhojpur, Dr. Gurung showed the picture how difficult terrain is to travel. And this was the scenario how he used to travel to the district hospital. And I want to highlight there is a good ladder or the steps to go to the temple, but there is always a bad road for the hospital. This is the context of our country. And then I was in Bhojpur for around 1 year. Then we ran many campaigns for hysterectomy, vasectomy and all. And this was the acknowledgement from the community that I got. And it made me more responsible for the community. Then, I was about to travel to Oman for a job to get a lot of money. But and in that meantime, I met Dr. Kasim Shah from NSI. He told me, what are your plans for the future? And I said, I'll earn little amount of money for my study that I want to do, and I want to study palliative care in Europe or somewhere if I get chances. For that, I need to earn money. And he told me that after a month, Patan is going to start a fellowship. Why don't you apply there? And so he was the first man to tell me that. So when I applied, and I came to Patan. And this was the study done by Binetara Foundation, integration of palliative care into medical school curriculum in Nepal. The study had shown that palliative care is a human right and essential for the improvement of quality of life, that we all know about this. What I want to highlight is palliative care was first included in the medical curriculum of the Patan Academy of Health Sciences in 2008. The credit goes to Dr. Rajesh sir for that. And in fellowship at Patan Academy of Health Sciences, it was providing palliative care since a long time, but formally a unit was established in 2019. And first such program to produce physicians who will be able to provide excellent care in the future. And luckily, I'm the first batch. We are two while joining. One of my friend, he quit in the middle of the course, and I continued the course. And palliative care, the mission of fellowship program is to produce specialists in the field of provide care, train other palliative care specialists and other health professionals, and take leadership to improve end-of-life care at national level. Fellowship program aims to develop physicians who are compassionate and socially responsible. A beautiful definition was given in today's presentation as what is compassionate is. We all say we have to be empathetic and compassionate. To be compassionate is a very difficult task. As already I said, that you educate and mentor other healthcare professionals, including nurses, midlife workers in palliative care, leadership in advocating palliative care, both local and international, national level, and encourage physicians to engage in relevant research within the palliative care field. And this is the course structure, how we are posted. It's a post-MD course of 18 months, 12 weeks in Patan Hospital, 15 weeks in Bhaktapur Cancer Hospital, where I met Dr. Vishnu sir, where he mentored me. In 15 weeks in Green Pasture Hospital, I'll be talking about it. 12 weeks in rural rotation in Makwanpur, 10 weeks in Hyderabad, and 13 weeks in Patan, and 1 month of exam. And this is the Patan Hospital, and it is our office. The first day, after cracking name in entrance examination, Dr. Rajesh asked us a question: why you chose palliative care? It's a very difficult task. We said, sir, working in the rural areas, now it's feeling like hectic life. So we want to come to the cities and sit there. And he laughed. And that was the answer that really I gave at the first time. There are other scenarios and other incidents which led me to palliative care. And this was the team. And there's the smallest one here, is my self-care. And in Patan, we spent 3 months in first time. In the first 3 months, Rajesh sir groomed us. He used to let us see the patients, but he used to groom us by asking us to write reflections. How do you reflect? What the patient might be thinking, what the patient family might be thinking, how you felt like a doctor. He groomed us like that. And then I was posted to Sunita project in INF GPH, palliative care and chronic disease service, where I met Dr. Ruth, Dr. Dan, Dr. Amrita, Dr. Dam Kumari, and everyone. They were the people who were working in the best environment of palliative care that is possible in Nepal. I usually say this in every platform because I have not seen speech therapist. Being a MD in general practice and working in different areas, I have not seen speech therapist. Occupational therapists I saw there. Physiotherapists working as a team for the patient care. So that was the best thing that I found in Sunta. They let me explore myself. I was very fortunate to accompany Dr. Dan to Rukum, to Lomjung. I was with them all the time. This is the palliative care ward where I worked with them. And this is the toolkit training that I first attended in Rukum. This was the team. This is the who are in, who are not. And this was me giving lectures. And this is me training to the healthcare workers in Rukum. So I was fortunate to learn from them a lot. I used to think that I am the one who used to walk in rural areas, but there were so much healthcare workers who used to work so far away from the centers I used to work. They were the real heroes. And then I was posted to Hyderabad, where the different scenario, but the social and psychological context were same, but the setup were different. Patient had a similar problem, like even today in the morning, even in the UK, there is difficulty of resources. They had good resources in Hyderabad, but social and economic condition of the patient were poor, like similar to Nepal. And it was a time for networking and learning from them. Then I came back and I was posted in Makwanpur, which Rajesh already talked a lot about. And I want to highlight few things that touched me. Oh, it's already 10 minutes, sorry, sir. This was the lady. Her husband had leukemia, refractory. Chinya sir and Kiyota, we three of us went there and saw the patient. And we prescribed medications, we counseled, and we came back. And our bike were parked at the top, and she was looking us from the down and saying, Babu, I forget to ask you tea. Come down, have a tea and go. So that was very emotional things that we get in rural areas. This guy with diagnosis, we made a diagnosis of COPD. He had never had an inhaler or MDI or anything in life. His saturation was 80, 81 around. We went to his home and we counseled, we prescribed medication, and providing Rotacab was also very difficult at this point, because from here, health post is 1.5 hours far, and you can't find MDI and Rotacab there in health post. So this is the real scenario of rural area in Nepal. And this type of houses and crowded family, socioeconomic status that we can imagine. I already said that the way to temple is quite good, but way to health post is very bad in Nepal. So we have to think on that also. And this is the picture that I didn't show the patient. Here the lady taught me how to use Rotacap. She used to open the cap of the capsule, and she used to keep outside, and she used to puff in. She taught me how to do it. And I told her that this is not the correct way of you are doing it. And she told me, no, this is the way the doctor taught me. And it took me half an hour to explain how to do that. And I said at last, in Nepali, I said that, Ama, tapai sahi ho bhane ta ma certificate jalaidinchu bhane. That means if she was right, then I'll burn down all certificates. And I sat down for half an hour and I taught her how to do it. Later on, our community health workers, they went and they refreshed and retaught her how to do it. So, being a general practitioner, I used to prescribe a lot of such medications, but I never thought of how they are doing it in their homes. This is the case of Makwanpur. This father has dementia, moderate, and COPD, and his wife is also having a COPD. And they both share the same Rotacaps. That was so touchy and loving, that thing I found and I kept it here. And he says that I sometimes forget how to do it, and she teaches me how to do it. So that was quite emotional there. And about this photo, Rajesh sir already showed how she is struggling to transport the patient from outside to inside. And we asked one question to her, how do you cope with these situations? She said, I drink little amount of alcohol in the evening to sleep. So we have to think about the caregiver also. And this is also the community photo. And in Patan, to pass the fellowship, we have to do one research which has to be publishable. And this was my research topic, resilience in caregivers of patients with palliative care need. It's at the verge of publishing. I just want to say the conclusion of it. This study showed resilience is associated with perceivable status of caregivers And types of diagnosis of the patients. That is, patient with neurological conditions showed low resilience scores than the patient with cardiopulmonary conditions and CKD. Therefore, the concept of resilience emerges as a possibility. Increasing resilience may improve caregivers' experience of caring chronic patients in the community. This study suggests further studies to understand the association of other variables as well as intervention for promoting resilience. So we have to work at the level of caregiver also, so for the comfort and for the quality of life of the patient as well as the caregiver. And there are two researches we have done, and upcoming research is also there. Already one has been published, Knowledge and Attitude Towards Palliative Care Among Healthcare Workers at Health Post Level in Mokanpur District. It has been already published, and one is qualitative research that we are at the verge of publishing, lived experiences of chronic patients in community of Tha municipality. It's a qualitative study. And then finally the day came. I passed my exam, and this before giving this certificate, Dr. Rajesh.
Please,
Yes,
sir.
sir. Yes, sir. Dr. Rajesh asked me, not asked, he didn't say anything a lot. He just endeavored, and this is the certificate that you have gained. But something he was trying to say to me, that this is not a piece of paper that you are getting. This is the responsibility that you have to bear. And in upcoming days, you have to take palliative care further and explore to the community. So, as already Bishnu sir said, man of palliative care, and he, with his 4 ventricles, 2 ventricles and 2 auricles working for the palliative care, I think to receive this certificate from the ultimate father of palliative medicine, Dr. Rajesh, is privilege for me. And and then I got opportunity to go to St. Jude Children's Hospital in America. We had a network, we shared each other's problem, and there was the same problem everywhere. It's very difficult to incorporate palliative care with the curative part. That was the problem with all the nations. So we learned from each other, and we hope that we will create a better environment for the patients. And from this unbalancing man to this man, I got a lot of support from everybody, from my teachers, my friends, and patients especially. So I would love to acknowledge all their helps and would like to thank. I think I won't cover much on this because universal health coverage and primary health care has been already covered. I just want to focus on GP palliative care specialists, why we need in our part of the world. Because of the holistic approach, we need GPs be working in the remote areas for the betterment or for the comfort of the patient and the family. And we believe in tele-mentoring, not tele-education or telemedicine, because we have to empower the local people who are working in the ground level. So these are the community orientation that we have given in Mokanpur, and this was for the policy and all. And benefit, I want to highlight one thing. It reduces costly hospitalization through effective symptom control, enhances coordination, preventing unnecessary treatment and service duplication. So rural palliative care is very important. We should be focused for the patient. And GPs are the backbone of rural palliative care. Equip them, empower communities. Palliative care is right, it's not a privilege. And this is the Chinia Lama who is working in community. Mokanpur model that we have heard about, the Rajesh sir explained. And I think thank you. If you have any queries, then I'm happy to answer.
Thank you, Dr. Rajkumar, sharing your experience as a first specialized fellow in Nepal palliative care program. If there is any question.
I just add some more points because I am working in improving the medical devices used since 10 years. So I'll just focus on the patient with COPD or asthma. If you, on my experience, I have encountered with many patients who are taking orally rotacaps, or they are inhaling from the nose instead of mouth. If you, because I did a systematic review and meta-analysis from the Nepalese data, and it shows that 2/3 of the patients did inhale their, or use their inhaler devices incorrectly, even in a critical steps. It means that we prescribe the appropriate medicine to the patients, but 2/3 of the patients have no effects because they are doing the error in the critical steps. So, yeah, I'm totally agree with that. And one of my question is that while you assess the patients, like it is also important because it is also important the device is more functional. Do you teach the patients, these are the critical steps, you need to must follow this. But these are the minor one. And also I think we need to teach the patients about the how to change your load rider devices or inhaler devices, how to maintain or manage your devices, because if device is not functional, then I think it is sure that the long diffusion of medicine is compromised. Do you consider that aspect or not?
Yeah, thank you for the question. It's a very pertinent and practical question that you have asked. That's why while I was in Makwanpur and trying to comfort the patient going everywhere, we found the same scenario. The patient has no compliance to the treatment. Because at the emergency condition, they used to search for where is my rota cap. And what we are trying to do is, we are doing one intervention. We have made a package of intervention for the COPD patients. We teach them how to use rota caps twice weekly. And we teach not only the patient, to the caregivers also.
I'll one more question. Because the evidence says that do you use the goal to teach approach?
Keep it short.
Sorry.
Did you use the goal to teach approach or just you teach the patient also?
We teach to comfort the patient so that they may get benefited with the medications and the intervention that we are trying to give.
Thank you, Dr. Rajkumar.
sir.
Thank you very much. Now.